So good morning, everyone. I'm Dr. Vaibhav Sheroran, and I'll be discussing about oromotor stimulation program in NICU. So we'll be covering this topic under the following subheadings: introduction, a history of oromotor therapy, then indications for oromotor therapy, then oromotor therapy techniques, and the feeding program we follow at our unit. Now, oromotor stimulation, it includes scientific sequential measures in which pattern stimulation is provided to perioral and intraoral muscular structures for strengthening them, thus facilitating normal physiologic feeding patterns and promoting physiologic stability and nutrition in preterm infants. Now, many of the strategies of the 1950s and 60s, they were primarily stimulation techniques such as brushing, icing, a quick stretch, and vibration. And they were developed by speech language pathologists. They started working with the occupational therapists, physiotherapists, and other professionals. Now, for the first time in 1977, a 3-day conference was conducted on oral motor function and dysfunction in children. In 1993 onwards, research articles started coming, but they were published by speech language pathologists and occupational therapists. But all these strategies, they were used to prepare a muscle area for movement, but cannot change the range of movement of a muscle or the strength of a muscle without additional muscle movement. And they also require the individual's cognitive cooperation to follow a command to complete a movement. Now coming to the indications, now there are certain stressors which may result in reduced durational muscle strength and thus may impact efficiency of nursing neonates. Now these factors can be antepartum factors like any infection in the mother, any preeclampsia, gestational diabetes, placenta previa, any preterm labor, intrapartum factors like any prolonged labor, requirement of oxytocin longer than 4 hours, any heart rate fluctuations, need for maternal oxygen therapy, any nuchal cord, any difficult extraction. Then postnatal factors like need for oxygen in the baby, any temperature dysregulation, hypoglycemia, neonatal hyperbilirubinemia, delayed breastfeeding, GERD, and neurological outcomes. So all these factors cause poor oral motor control in the baby, weaker muscle tone around mouth, and less sensation and less tongue strength. So these babies are put on long-term IFT feeding, which has been associated with esophageal inflammation, pharyngeal desensitization, and increased risk for gastroesophageal reflux. So these babies are also found to be associated with feeding disorders, which are later associated with deficits in cognitive development, behavioral problems, and eating disorders. Now, coming to the oromotor therapy techniques, the various techniques are first is MOM-BEST, that is the manual oral motor breastfeeding evaluation screening tool. So it basically is a screening tool which screens for mechanical oral motor concerns in baby, then tests for assessing readiness for feeding, our neo assessment tool, the neonatal eating outcome assessment, and the infant-driven feeding scales. Now, the OMS techniques per se are Beckman oral motor intervention, the BOMI, or the premature infant oral motor intervention, commonly known as the POMI. Now coming to the screening tool, so it basically screens for mechanical oral motor concerns using two components of nutritive suck. First one is the durational jaw movement, wherein small finger is placed between posterior gums for 10 seconds, then repeated on left and right side. Then the number of jaw compressions are counted in 10 seconds. The second component is the mid-blade tongue elevation, wherein the finger is placed at the middle of the tongue blade, then the tongue is depressed and the finger is moved back to hard palate. Then we feel for mid-blade tongue elevations within 1 second, and then it is repeated for 3 trials. Now, if failure for either occurs, then the baby is referred to therapist for full motor assessment. Now coming to the test for assessing readiness of feeding, this is a neonatal eating assessment tool. This is a new assessment tool which is commonly used in our unit, in which we assess the pre-feeding behavior of the baby, wherein it is divided into these parameters like we assess arousal state, physiological stability, respiratory support, rooting and grasp, initiation of sucking, tongue and non-nutritive sucking, whereas they are further subcategorized into the following subheadings where the baby is given a score and the final score is interpreted as if the score is between 6 to 20, then the feeding would be a challenge in the baby. If between 21 to 26, it is questionable. If 27 to 30, it is a normal score and the baby can be started on feeding. The second one is infant-driven feeding scale, wherein the baby is scored from 1 to 5, depending on the condition of the baby, wherein the 1 indicates that the baby is most ready to feed and the 5 indicates that the baby is least ready to start the feeding. Now coming to the techniques per se, first one is the Beckman Oral Motor Intervention or the BOMI. This protocol was developed by Beckman and is of total duration of 15 minutes. It uses mechanical, non-cognitively mediated muscle responses to seek responses to different stimuli. Now, different pressures, movements, ranges of motion, force, control of lip, cheek, jaw, and tongue movements they are applied, and they provide assisted movement to activate muscle contraction and movement against resistance to build strength. The focus of these interventions is to increase functional responses to pressure and improve movement, range, strength, variety, and control of movements. Now, the interventions needed, they are determined by an assessment tool, the Beckman Oral Motor Protocol, which uses these assisted movements and stretch reflexes to quantify responses to pressure and movement, range, strength, variety, and control of movements for the lips, cheeks, jaw, tongue, and soft palate. So the assessment is based on clinically defined functional parameters of minimal competence, and it does not require cognitive participation of the individual. Also, these components of movement are functional, not age specific, and they are of diagnostic categories. But the problem with BUMI is it is not suitable in preterm infants due to the smaller oral cavity and the longer administration time. These are the 11 parameters which we test in the Beckman oral motor intervention. Now coming to the premature infant oral motor intervention or the POMI, it is a 5-minute oral motor intervention using little finger in and around the mouth of preterm infants from 29 weeks post-menstrual age, and it was developed by modifying the original BUMI tool. Now it aims to mimic the in utero oral experience that strengthens and develops feeding mechanisms. The 8 steps they provide assisted movement to activate muscle contraction and provide movement against resistance to build strength in areas needed for subsequent bottle and breastfeeding. Now, the intervention increases functional response to pressure and improves control of movements for the lips, cheeks, jaw, and tongue, and results in more sustained breastfeeding at 1 year of age. It has also been observed that POMI significantly improves neurodevelopment after discharge in gross motor, fine motor, and social emotional domains, and better outcomes on the infant at 1 year of age. Its advantages over BOMI tool is it has decreased number of steps and length of time. Then it can be used specifically in preterm infants as young as 29 weeks. In the BOMI's original 11 steps, they are consolidated into 8, and the 15 minutes are reduced to 5 minutes. These are the basic 8 steps which we see in POMI. Then we'll be discussing about these one by one. First step is the C stretch, in which a finger is placed inside the cheek and one on the outer cheek. Now slide and stretch from front to back towards the ear, then down, then back to front, following a C pattern. Then it is repeated for both sides. So it is used to improve range of motion and strength of cheeks, and it improves lip seal. So done for a total duration of 30 seconds and repeated 2 times on each cheek. Now coming to the second step, it is the lip roll. Place a finger inside the cheek and one on the outer cheek. Slide and stretch front to back towards the ear, then down, then back to front, forming the lip roll. And a finger is placed on the inside and one on the thumb on outside of upper lip. Then move finger in horizontal direction while moving thumb in opposite direction, rolling lip between fingers. It is done on the left side of the lip, then repeated on the right side. It is done for a duration of 30 seconds and improves lip range of motion and seal, done 1 time on each lip. Now coming to third, it is the lip curl or the lip stretch, in which a finger is placed on outside of upper lip and one on the inside. Then gently compress lip and stretch downward towards midline, moving across lips. Now it is repeated on lower lip, stretching upward. But if the lips are too small to grab, then a lip stretch is done, in which finger is laid across the upper lip, slightly compressing tissue, then move tissue horizontally, stretching to one side, and then repeated for bottom lip. Now it improves lip strength, range of motion, and seal, and done for a duration of 30 seconds, 1 time on each lip. Now the next is the gum massage, in which a finger is placed on left side of the upper gum with firm sustained pressure. Slowly move across the gum to the other side. Now move down the lower gum to continue a circle with firm sustained pressure. Slowly move across to the other side. Now done for a duration of 30 seconds, and it improves range of motion of tongue, stimulates swallow, and improves suck. Now the next is the lateral borders of tongue or cheek, in which a finger is placed at the level of the molar between the side blade of the tongue and the lower gum. The finger is moved towards midline, pushing the tongue towards the midline. Then move the finger back and all the way into the cheek, stretching it. Now done for a duration of 15 seconds, and it improves tongue range of motion and strength. Now the next one is midblade of tongue or palate, in which the finger is placed at the center of the mouth, given sustained pressures into the hard palate for 3 seconds. Now move the finger down to contact center blade of the tongue, then displace the tongue downwards with a firm pressure and move the finger back up to the center of the hard palate. Then for a duration of 30 seconds, and it improves tongue range of motion and strength and improves suck. Now the next is eliciting a suck, in which a finger is placed in the midline in the center of the palate and gently stroke the palate to elicit a suck. Now done for a duration of 15 seconds, it improves suck and soft palate activation. The last step is the support for non-nutritive sucking, in which a finger is left or a pacifier is put in the baby's mouth and baby is allowed to suck. It done for a total duration of 2 minutes and improves suck and soft palate activation. Now coming to the feeding program at our NICU for preterm babies, babies that are less than and equal to 36 plus 6 weeks of gestation, they are enrolled in the preterm feeding program. When they are on room air or on minimal oxygen support, hemodynamically stable for the last 72 hours and are on some feeds including MEN. Now one return call per baby is sent to NRC for POME provider, which will suffice for the entire duration. So the POME team will come and they will evaluate the baby for feeding readiness using the NEO tool, provides POME, provides oromotor strengthening, and cue-based feed advancement is done. And now for the term babies, they are evaluated for feeding readiness using the NEO assessment tool. And if required, then a call is given for physiotherapist for the oromotor assessment. So we have a dedicated lactational counselor who comes on every alternate days to counsel and assess for breastfeeding in the NIC. Now, thank you. Thank you from Team Guardian.